आवाज नहीं आ रही। That is इसकी Hello. Can you hear everyone? Morning everyone. Good morning all. Good morning to all. जिंदा हो? अब लग रहा है। ब्रेकफास्ट नहीं किया? गंदा सा, गंदे वाला? अभी कैंटीन में मिलता है। क्या मिलता है? इसमें क्या मिला? ब्रेकफास्ट पकोड़ा। बस। जो नाले वाला है, नाले के रोड में। दुक्का जी वहाँ खाते तो फिर नाली की खुशबू आती है ऐसे साथ। अच्छा लगता है नहीं? ठीक है, आवाज आ रही है पीछे? ओके, तो रिवीजन तो आपने किया होगा। I'm very sure everyone. Okay, who did not revise till now? Raise your hands. If you are not under revision, raise your hands. 1, 2, 3, 4, 5. 5. Who have done the entire till major parts now? So पहले who have done the entire 1, 2, 3, 4, 5, 6, 7, 8. बाकी 52 से नहीं चलेगा। आप कहते हैं 50% मार्क्स आने से पास करने की पढ़ाई की पूरी नहीं चलेगा। So when you do the revision, just of it tonight. Okay. Any doubts so far? Any doubts from anything that you have done till now? No. Very good. If you don't have doubts, ये तो दो बातें हैं। ये तो आपको सब कुछ समझ में आ गया। मैं बहुत अच्छा पढ़ाता हूँ। और ये आपको शर्म आ रही है किस तरह से क्या पता जाए। मुझे क्यों हो जाएगी सबके सामने? कौन सा वाला सही है? पहले वाला? Okay. So I told you yesterday that this is the most important topic. One of the very important topics of the past month. And questions are very frequently asked on here. But they just 6 or 7 points and they're simple points. And one of the points you already know is the most common site. Is it the most common site? Most common site. Fossa prosobular. The most common site is fossa prosobular. And then they ask the type also. Type. There are 3 possible types. Type 1, type 2, type 3. Some books will call it type 1. This is type 2A. And this is type 2B. So it depends on book you read. Both are correct. Type 2B, which is the third one, is also called undifferentiated stomach cell carcinoma. And this is the most common type. It is a very important MCQ. But this is the most common type. Type 3 or 2 or undifferentiated, whatever is written with process, that becomes the correct answer. Cross. What causes the carcinoma? A virus. Which virus? Epstein-Barr virus. Another very important MCQ. The virus that causes the carcinoma is a very important question. Besides the virus, it can also be caused by genetic predisposition. It can also be caused by a chemical called nitrosamine, which is found in smoked fish. So overall, these are the three factors. It can be caused by virus, it can be caused by genetic factors, it can be by nitrosamine in the smoked fish. And these two are forming Chinese people. Chinese and Hong Kong. So now Hong Kong is China, so Chinese people use it. That's why if they ask you which country has the maximum cases of nasal carcinoma, it is China. And if you consider Hong Kong separately, then China, Hong Kong, that area. The maximum number of nasal carcinoma. Huh? And now comes the most popular question from this disease. This is a very, very important MCQ. That most common presentation. Who will tell me the answer? Cervical नहीं है, cervical है. Cervical sir. ऊपर ही anatomy करो cervical lymphatic होता है. क्या बढ़ लगी है? नहीं है. Okay. कितने लोग भागे आए? अब सारे हाथ तो ऐसा तो तुम्हें भागा है? कौन है वो? पर भाई ये आपका तिवारी कहाँ है? And this is a very important MCQ. Okay. Extremely important MCQ that besides this, there can be other features like we know about blue ear. Remember, in adults with blue ear causing hearing loss. This is possible. Then nerve involvement can happen, cranial nerves. And one more thing, which is very important, is shorter start. So these are some of the presentations of a nasal part. All the paper, these are the important ones that you have to remember, especially the first and the last one. First one, the cervical lymphatic patch, because it is very important, very common, the most common, and the last one because it's a triad. And because triad, we will have three features. And this is MCQ. What are the three features of process triad? Yes, one is soft palate palsy. Hearing loss and facial pain on the face. Okay, so these are the three features of process triad: soft palate palsy, hearing loss, and facial pain. And this is another very important MCQ. About process triad, they ask you either the three features, these three that are given, or they will ask you it's a feature of this disease. It's a feature of nasopharyngeal carcinoma. Okay, that's it. Investigation, of course, you do CT scan plus biopsy. Because biopsy you have to do nasopharyngoscopy, that we know already. You have to do nasopharyngoscopy, do biopsy, simple histopathological examination, and treatment of choice is another question. The answer is chemoradiation. This is a better answer, best answer. Chemoradiation is a treatment of choice, especially radiation, because there is a note here. Nasopharyngeal carcinoma is the most radiosensitive carcinoma. In head and neck area. So in this area of ENT, head and neck, this is the most radiosensitive carcinoma. That's why it is important. So Like I told you, there are few points, 6-7 points, but they are all very, very important. You can almost assume that they are going to ask you a question from here, maybe from the classroom. The next disease is a benign tumor called juvenile mesothelioma angiofibroma. What's your name? What's your name? We're done in years. We're doing which year? Which year? Done. You look like a school student. Class 12. Yeah. Okay. It's so tiny, I guess. Time, no? Okay, mesothelioma angiofibroma. DNA. You know the site? What is the site? Spinopalatine foramen, right? Do you remember where is it located? It's here, isn't it? And the tumor is like this. So this is a tumor. Like this from the spinopalatine foramen in the nose and nasopharyngeal of course. What type of tumor is this? It's a fast growing or aggressive. Somebody saying it is benign and vascular tumor seen only in juvenile males. Fast growing, aggressive, benign and vascular tumor seen in only juvenile males. What is juvenile male? What is juvenile age group? Around 10 to 16 roughly. Even 8 is considered juvenile. And only males, never in females, never in adults. It's never in females, never in adults. It's a dangerous tumor. Although it is benign, it is dangerous for 2 reasons. It's vascular and it's fast growing. So presentation. What is the most common presentation? Make a guess. Recurrent and severe epistaxis. And we all know what is epistaxis, isn't it? Nasal bleeding. So these are vascular tumors will start bleeding from the nose. And if a male child, a male of around 10 years, 20 years has an epistaxis, nasal bleeding, this is the most important cause. Cheek swelling is another very, very important problem. Blue ear can happen because station 2 is nearby, so blue ear is possible. And tumors can involve nerves, so nerve involvement is also possible. So these are some of the common presentations in a juvenile nasopharyngeal angiofibroma. Where it's given here. The first 4. Recurrent severe epistaxis, nasal blockage, cheek swelling, hearing loss, blue ear, and nerves. यही है वो last one. Same thing. The most important thing that they ask are the last 2, that is written in red. The 2 signs, these are very, very important signs. This is the most commonly asked question from nasopharyngeal angiofibroma. The two signs, antral sign, which is also called Hallman-Miller sign, and frog face deformity. Antral sign is also called Hallman-Miller sign. This is an extremely important MCQ. And frog face is also MCQ. What is frog face? When there is proptosis, as given here. So if angiofibroma causes proptosis, that's called frog face. But what is antral sign? In antral sign, the posterior wall of maxilla is pushed anteriorly. This is antral sign. The posterior wall of maxilla is pushed anteriorly. And you can't see this area clinically. You can't examine this. Therefore, to see this sign, what do we do? A CT scan. We do a CT scan because you can't see the posterior wall of the maxilla. That area you can't see normally. They can be seen on CT scan. Antral sign is a CT scan finding. Whereas frog face is like a clinical finding. You can see the proptosis. Where is proptosis? Eyeball is pushed by the tumor. Yeah, eyeball is pushed by the tumor. Proptosis. But antral sign is this. Scan like I told you. Look at this maxilla. This is a normal maxilla. This one is a normal maxilla and this is a posterior wall normal. And look at this maxilla and look at the posterior wall. This arrow you can see. So there is a tumor here and the tumor is pushing the posterior wall of the maxilla anteriorly. And this sign is called the antral sign. Compare this maxilla with the normal side maxilla, the other side. Then you realize it. There is a huge difference in the posterior wall. And this is an axial view. The first one is an axial view. And look at this sagittal view. Again, maxillary wall is supposed to be like this much. But it has been pushed by the tumor, as you can see the red arrow. And the posterior wall of the maxilla is pushed anterior direction. This sign is an antral sign. Right? But look at the green arrow in the second graph, the second scan. The same tumor, which is this one, is also trying to enter the orbit. So if it goes into the orbit, क्या हो जाएगा? Proptosis है देखो what sign? Frog face. It can lead to frog face deformity, which has not happened yet. But if you don't treat this patient in a few days, the patient will have a proptosis and frog face deformity. So this image is very important. Okay. Now there are many types of grading or classification or staging you can see for angiofibroma. These are some of the common names of the stagings that are used for, and the names are important. Here's the names. The 5 names: angios, standards, Rodinski's, Sessions, Fish. The names are important. So remember the names, the 5 names. These are all different stages. Andrews classification, Sanders classification, Rodinski's classification, Sessions classification, and Fish staging. Don't write the staging, don't write all this. Only these 5 names. obviously there are different classifications for the same tumor. Therefore, they'll be little different from each other. But what is interesting about all the classification, which is important for you to know, is that this classification is different from each other. All these classifications are slightly different from each other. But stage 2 is nearly same for all of them. Nearly same. And that's why if they ask you, they'll ask you stage 2. They'll give you any name and they ask you stage 2, which is nearly the same. So you don't have to know everything. And if you remember, stage 2 is this one. When the tumor spreads to what is called the pterygomaxillary fissure. The other name for pterygomaxillary fissure is pterygopalatine fossa. Pterygopalatine fossa and pterygomaxillary fissure are same thing. And when the tumor spreads from the nasopharynx to this area, it becomes stage 2, whether it is Andrews, whether it is Chandler's, whether it is Robinsky's, Sessions, or Fish. It's nearly the same. Yeah. And finally, the treatment. Since a vascular tumor and benign in nature, have we discussed any other benign vascular tumor before? Which one? Glomus tumor. Remember in the year is benign vascular tumor, this was a benign vascular tumor. So the management of both all vascular tumors are the same, which is embolization, followed by surgery. And what are the surgery option you have? Two options. Either laser or bipolar cautery. Isn't it? Where surgery cannot be done, you have an option of radiotherapy and chemotherapy. The same thing almost. But no alpha blockers. Remember? In that case, we also give alpha blockers. Here there is no alpha blockers. It is not useless. Instead, there is another option. You can give hormonal therapy. There is an option of hormones also. So this is the only difference between the two. In this case, hormone therapy is an option. In glomus tumor, alpha blocker is an option. The rest of the three are same because they are similar tumors of different sizes. And this will complete the nasopharynx. So what have we done in the nasopharynx? We have talked about the adenoid hypertrophy. Remember that breathing child with adenoid faces. Yeah, that adenoid faces mean how many features? 5 features. Now you are going to turn your pages to see क्या है. याद है? Anybody who remember? 5 features. नाम याद है? Adenoid faces. ऐसे भी दिखाया था adenoid hypertrophy. High arch palate, crowding of the upper teeth, pinched nose, which is called ala, and hypoplastic maxilla and the long face or dull expression. याद रखना कितना मुश्किल है ना? वो रात दी तो बात नहीं. शाम को पढ़ा था सुबह तक साफ हो गया मेरा जीवन पूरा था वही वाला. That's why revision is important. This is the important thing. Revision के बिना तो काम चलेगा नहीं. And the sooner you do, the better it is. The more you postpone the revisions, the more difficult it becomes. Because if you do revision today, then class में जो बातें थी वो भी याद आती है. If you do after 3 days, you forget all the nitty-gritty, but you are not prepared, you are not recall. That's why revision, the first revision should be done. And I'm quite sad that many of you have not revised. And you have ample time. अगर शाम को क्लास भी नहीं थी, ENT के बाद कुछ हुआ था? नहीं. फेसबुक हुआ था सर, व्हाट्सएप हुआ था, है ना, यूट्यूब हुआ था, पढ़ाई के अलावा। बच्चे बातें मत करो, ध्यान दो। If I ask you questions, then you feel bad. दोनों बच्चा और वो तुमसे भी कह रहा, दोनों तब से बातें लगे रहे, नहीं बातें खत्म नहीं होती क्लास में। Okay, so what we have done the adenoid hypertrophy, we have done coronal atresia, we have done major family carcinoma, we have done angiopharynx. We are the dealing with the major pharynx. Coronal atresia का वो लाइफ सेविंग टेक्निक याद है किसी को? मैकडॉनल्ड्स बर्गर, मैकडॉनल्ड्स मैकडॉनल्ड्स टेक्निक, लाइफ सेविंग टेक्निक, है ना? It's very important. Now we go below the nasopharynx and come to this area, which is this area. What is it? Oropharynx. Oropharynx. In the oropharynx, the only important thing is the palatine tonsil. Palatine tonsil is the only important thing in the oropharynx. The main tonsil out of the 4 in the ring. What is the ring called? Walden's ring. Anna? Tell me 2 things in the palatine tonsil that are not seen in adenoid. दो बातें. Capsule and crypt. And the longest crypt is called crypta magna. Longest crypt is crypta magna. Okay, how many of you remember the 5 arteries of the tonsil? Raise your hand. Don't say. Everything you can do. Tell me the 5 arteries of the tonsil. Raise your hand. 1 person. 2. Yes. तुम बताओ. Tonsillar artery, very good. Ascending pharyngeal artery. Ascending palatine. Descending palatine. Dorsal palatine. नाम बताओ. स्नेहासी से खाली बताओ. Very confidently he said all the 5 arteries without any glitch, है ना? और वो याद रख सकता है तो आप तुम ये सवाल ही है अपने ये he can remember why can't I? वो तो निकल जाएगा, आप तो रह जाओगे। अगले साल वो पीजी की तैयारी करेगा, आप फिर से ये करोगे, नहीं करोगे ना? तो इसलिए क्या करना पड़ेगा? याद रखना पड़ेगा। And that's the only challenge. Class में बैठ के नोट्स बनाना is not a challenge. उसको याद रखना is a challenge. And that is only possible if you do the revision. So revision is a key. ज़्यादा बोल रहा हूँ ना revision फिर भी आप नहीं करोगे, लोगों को पता है. Okay, so anatomy we know of the tonsil, and in tonsil there are only 2 things other than the anatomy. One is the infection of the tonsil, which is called tonsillitis, and the surgery of the tonsil, which is called tonsillectomy. Tonsillectomy is a very, very, very important topic. So we'll mainly talk about tonsillectomy, but few things about tonsillitis, which is the inflammation of the tonsil. Now tonsillitis, which is inflammation of the tonsil, which is a very common problem, has types. How many types? There are 5 types. The most common type is called catarrhal tonsillitis. This is caused by adenovirus. So we call it viral tonsillitis, and like I said, this is the most common type of tonsillitis. Catarrhal tonsillitis caused by a virus. It's a viral in origin. Mainly adenovirus, the other viruses that can cause, and this is the most common type of tonsillitis. Even pharyngitis can be caused by the same virus. So tonsillar pharyngitis we call it, both are infectious. The rest of them, they are usually bacterial, like we have what is called follicular tonsillitis. We have membranous tonsillitis, parenchymatous tonsillitis. These 3 are caused by bacteria. So the bacterial origin is Streptococcus. Which one? Pyogenes. Caused by, this is another very important MCQ. The bacteria that causes tonsillitis is Streptococcus pyogenes. And the 5th type is fibrinoid. Fibrinoid is non-infective tonsillitis, non-infective inflammation of the tonsil. So there is no pathogen here. We all know inflammation generally need infective. You can have inflammation without infection also. This is one of those ones. So remember all the four, all the five actually. Now, the names are given basically because of the findings and the pathogens. But otherwise, the presentation of all the tonsillitis are very much similar. You understand? Tonsil in the form oropharynx, and it is enlarged, it is swollen, red, and all that. So it's going to cause pain in the throat. It can cause a swollen difficulty, speech defect, and all that can happen. One important symptom is hearing. Tonsillar problem can also cause pain in the ear. Now, this is a question: why should the disease of the tonsil cause pain in the ear? Their tonsil throat में है, ear कहीं और है. So why? They ask you, why will tonsil disease cause pain in the ear? बेगामी शादी में अब्दुल्ला दीवाना सुना? स्लाइड है. शादी किसी को भी दीवाना अब्दुल्ला हो रहा है. उसकी एक्स थी वो, इसलिए वो दीवाना हो रहा है बेसिकली. वो इसी होते हैं बेगामी शादी में अब्दुल्ला दीवाना. रिलेशन क्या है दोनों में? शादी में अब्दुल्ला में एक रोमांस जुड़ा हुआ था, वो गड़बड़ हुआ. तो यहाँ पे भी कुछ जुड़ा हुआ है. क्या जुड़ा हुआ है? नर्व. कौन सी नर्व? That's the question. Which nerve? Facial nerve never causes pain. Facial nerve में pain कभी नहीं होता. Facial nerve याद है? Motor है. फिर glands में parasympathetic है. फिर taste है. Sensory तो सिर्फ small screen में करना है. Pain किससे होता है? Pain is somatic, sensory. And facial nerve is hardly sensory. It's a very small screen. So facial nerve will never cause pain. So keep that in mind. Loss of pain. Ninth. Tonsil में कौन सी nerve है? I told you tonsil में कौन सी nerve है? Ninth nerve. तो tonsil का कुछ भी होगा तो ninth nerve से ही हो सकता है. Any pain referred from a tonsil will be referred by ninth nerve. Any part of the ear is having ninth nerve. Ear में होती ninth nerve. कहाँ पे? Middle ear. याद है? The ninth nerve causes the toxins and tympanic plexus. So this is the relation. Tonsil may be ninth nerve or middle ear to ninth nerve. That's why one problem can refer to the other. It's like Durva. It's a bit like Durva. It's connection. नहीं देखी देख लेना जाए. तो देखी है. तो एक को चोट लगती है तो दूसरे को भी दर्द होता है. So this is the same thing. They are Durva. What is the connection? The connection is the ninth. Right. So if there is a problem in one, pain in one, the other will also refer to stop. So the tonsil has a problem. Middle ear will have a problem. If the middle ear disease, the tonsil can have a problem also. It's like a Durva. So there is a connection. This is called neuralgia. What is called? Neuralgia, or even called referred to. Either referred pain or neuralgic pain is called. So these are the terms that we use. And this is pretty common. This is नहीं तो नहीं है. It can happen to other nerves also. And sometimes they ask, other things also. We'll have one more important thing. We'll discuss that a little later, seeing similar situation. But remember this, that anything in the tonsil oropharynx, it causes pain in the ear, it is because of loss of cranial nerve. It's a referred to. It is referring from one area to the other area. So that's the possibility in a tonsillitis. And many of the people will only have one complaint, this one. There is no other complaint. आप कान में ढूंढ रहे हो problem. What is the problem? So it's very difficult sometimes to diagnose these cases. Now, what is the difference between tonsil and follicle, membrane and follicle? Do you know the crypts? Crypts are what? Like tunnels, remember? But you can see the tunnels if you cut the tonsil. If you look at the tonsil, the tonsil ऊपर से देख रहे हो, the crypts they look like small openings. They look like how many crypts? 10 to 15. But if you go inside this crypt, then you feel this tunnel. ये मुंह है tunnel, right? And when this tunnel gets filled with pus, so you can see only pus points. These are called follicles. They look like follicles. So follicles are nothing but pus points on the tonsil. Point दिखेगा pus points. But when you look at the pus points on the tonsil, you are looking at the tip of the iceberg. असली पस कहाँ पे है? इसके अंदर है. The tunnels are filled with pus, but you can't see that. Now, in this patient, if you squeeze this tonsil, like a sponge, and if you dip a sponge in the water, you can't see the water. It's falling like a sponge. But if you squeeze the sponge, itna sara pani niklega usme se. Same is the case here. When you squeeze this tonsil, then you realize it's all developed out. But if you don't treat, they will keep on expanding. First, banta rahega, बढ़ते रहेंगे इस size में, and when they become too big, they join with each other. That is, and now it is called membrane. This is called membrane. It looks like a membrane now. So that's why I asked, what is the difference between follicle tonsil and membrane in the tonsil? Actually, it is the same thing. Only when they are individual, they look like follicles. When they join together, it begins to look like the membrane. That's why, in the same tonsil, like I've shown you, some areas can have follicles, this area can have a membrane also. So in this, which is the follicles, which is the or this no membrane media. So follicles and membranes can be seen together in the same tonsil. It is actually the different stage of the same process. Because same way, शुरू में follicle बनता आगे चलते membrane जैसा लगने लगता. And so when you see the two together, you should not get confused. Like if you look at this tonsil and this tonsil, the small ones are follicles, and this big one is membrane. The small ones are follicles, and these big ones are membranes. Because the follicles and the membrane in the same side, that's why it's called follicular tonsillitis and membranous tonsillitis. Membranous tonsillitis is also called streptococcal tonsillitis because it's called by streptococcus. And they ask you, what is the most common cause of membrane in throat? Which is the most common cause of membrane in the throat? इसको बता रहे सिस्टम में क्या So tell me the answer.
Streptococcus pyogenes.
Same, यही वाला membranous tonsillitis. Membranous tonsillitis is the most common cause of membrane in the throat. Yes, Pankaj, you are right. And diphtheria is a very important cause. Diphtheria is also an important cause. And third important one is infectious mononucleosis. Out of many, these three are the ones that you must remember. Membranous tonsillitis, diphtheria, and a lot of people think that diphtheria is the most common cause. It used to be, not anymore. This is better. नहीं चल रहा ना? कौन सा नहीं चल रहा? फूक मारो. ये भी कहाँ से हमारी है तो बहुत दूर है सीरियसली पता चल रहा है हाथ तक मैं तो उसको बुलाएंगे इससे नहीं चलेगा रिमोट से नहीं चलेगा नहीं सबको जानते okay. So these are some of the important causes of membrane in the throat. Just remember this. Now, I told you the symptoms or the presentation of most of the tonsillitis are very similar to each other. We gave an example. And what is the treatment? The first line of treatment is medicines. Medicines is antibiotics and painkillers and all that. And if this fails, then we do tonsillectomy. The surgery of the tonsil, tonsillectomy. And I already told you in tonsil, the most important thing is tonsillectomy that we have to do. So we are now going to talk about the most important topic of the oropharynx, tonsillectomy. Now, when we talk about tonsillectomy, we discuss tonsillectomy in 5 headings. We talk about indications. We talk about contraindications. Few things about the procedure. सबसे important, complications. Very, very important. And procedures, I mean methods of doing tonsillectomy. Complication is very, very, very important. Complication of tonsillectomy तो आपको आना ही चाहिए सारा. You have to remember all the complications of tonsillectomy. But we shall discuss start with indications. So these are the common indications for tonsillectomy. The most common indication is recurrent tonsillitis. Also chronic tonsillitis. Recurrent tonsillitis and chronic tonsillitis are the 2 most common indications for tonsillectomy. Then rheumatic tonsillitis is also important. Hemorrhagic tonsillitis. Correct, Pankaj? Suspicion of malignancy. When you suspect a malignancy in the tonsil. Then quinsy. We will discuss what is quinsy, so you know what is quinsy. We will discuss in 12. And we will also discuss the Eagle's disease. Yeah, you can see obstruction. Correct. Sometimes you can see obstruction. Right? So the list is even longer than this. Here the main causes, the minimum causes actually 5-6 more causes, but here the one that you must remember. The main causes of main indications of tonsillectomy. These 7 names you have to remember. The next thing is contraindication. The most important contraindication is bleeding disorder, bleeding problems. You know, in tonsillectomy, surgery is not a difficult surgery. There is only problem in tonsillectomy, bleeding. Tonsil surgery is not difficult, but if the patient starts bleeding, which is very common, then it can create a lot of problems. And if the patient already has a bleeding disorder, then you can be sure that you have a very bad time doing the surgery. Then acute infection, acute tonsillitis. See, you can do in recurrent, you can do in chronic, but you cannot do in acute. And the third is epidemic of polio. Polio epidemic. Okay, so these are some of the contraindications for tonsillectomy. Easy. Third thing, we have to know few things about the procedure while we are doing tonsillectomy. 2 of the things. A, what is the position of the patient doing tonsillectomy? The name of the position is Rose position. Remember this name is an MCQ. Rose position is the position that is used to doing tonsillectomy. Who remember the position between pelvic rest? Supination and the head is raised by 30 degrees. That's supination and the head is raised by 30 degrees. In tonsillectomy, it is Rose position. And you know that the tonsillectomy is done through the mouth. So during the surgery, the mouth of the child has to be kept open. And for that, an instrument is used. And they ask you the name of the instrument that is used to keep the mouth open. at the time of surgery. It is this. It is same as this. This instrument is called Boyles-Davis mouth gag. Boyles-Davis mouth gag. The name tells you mouth gag, so you know it's keeping the mouth open. This is the main thing. Ye wala is same as this. The same. This is the main thing. And all these are blades. These are blades that are applied. And the different sizes of blades based on different age of the child. For small child, you use a small blade. For elder child, you use a long blade. So this is a Boyles-Davis mouth gag. The name is more important. Image most probably did not ask you. Name is a MCQ. And I'll show you an image how it is used. See, this is the mouth gag being used. In the first image, they are applying it. It's not applied properly yet. And the second image, it is already applied. And you can see the mouth is wide open. And you can even see the tonsil through the mouth. I think surgery becomes much easier. So this is this surgery being done. This is tonsillectomy being done. And when you do a tonsillectomy, when you cut the tonsil, they ask you to the instrument that is used to cut and remove the tonsil. And that instrument is this one. And this instrument is called Eve's tonsillar snare. Eve's tonsillar snare is the final instrument that is used for tonsillectomy.
पानी गाल दें.
So two important instruments in the tonsil. One is Boyles' mouth gag, and other is Eve's tonsillar snare. What does Eve's tonsillar snare do? Yeah, I'll show you. This is a diagram where you see that tonsil is being cut by this. This is the Eve's. Which one? This is the Eve's tonsillar snare. This is the Eve's tonsillar snare. And you can see the tonsil is cut, isn't it? So what does it do? That's the question. What does the Eve's tonsillar snare do? When we crush first the tonsil. So we don't just cut the tonsil, we crush the tonsil before we form. Crush को हिंदी में क्या बोलते हैं? कुचलना, काट, कुचल के काट डालेंगे, है ना? It's like tonsil को कुचल के काटते हैं, जैसे लगता है ना दुश्मनी निभा रहे हैं, कुचल के काट डालो मत। क्यों कुचलते हैं? Why crush? Why crush? Because when you crush the tonsil, it releases a chemical called thromboplastin. When you crush the tonsil, it releases a chemical called thromboplastin. And this thromboplastin converts prothrombin into thrombin. And the thrombin converts fibrinogen into fibrin, and fibrin helps in coagulation. It's basically going to help you control the bleeding. This crushing is indirectly going to help you help in coagulation or bleeding. And actually in tonsil, bleeding is a very big problem. And this crushing actually helps in preventing the bleeding. When you crush something, a tissue, it should bleed more. But when you are crushing it, it is actually helping you bleed less. It is controlling the bleeding by this process. So that's why we crush and cut the tonsil. And for that we need a special instrument called Eve's tonsillar snare. But nowadays we have better, more advanced technologies where we can do a tonsillectomy. Like, you know, cautery. So if you do a cautery, you don't need all this. Cautery is itself is I told you, it formulates as we cut it. So similarly, we have laser and we talk about. That's what we talk about in methods. Remember, the last topic is methods when we tonsillectomy. So we have better methods now, but still, this is one of the most commonly used methods in India. This crush and cut. It's called snare. We snare the tonsil. What do you know of the instrument? We consider snare. What is the meaning of the word snare? Snare is cut, crush and cut. So in India, we still snare the tonsil. We don't use the advanced technology because of cost factor. New technology comes with money. And India people are very price sensitive. It's like purchasing a simple iPhone and an iPhone Pro Max. Pro Max में साथ ज़्यादा कुछ है लेकिन आजकल वो फोल्डिंग वाला आ गया ये लेकिन पैसा निकाल रहा है ना लोग बोलेंगे ये भी फोन है काम भी कॉल भी वही आवाज सुनिए आवाज में तो फर्क होना नहीं है तो क्यों हम ज़्यादा पैसे दें इंडिया में वाली सोच इंडिया में आदमी फोन तो फिर भी खरीदेगा आईफोन प्रो मैक्स लेकिन ये नहीं करवाएगा बोलेगा सर ये ठीक है क्रश if you tell you if I tell you to crush and cut I'll take 50,000 rupees and laser I will take 90,000 rupees आप लोग सर काउंसलिंग निकलेगा ना दोनों में आप लोग यहाँ काउंसलिंग निकलेगा बस तो फिर 90,000 के खर्च करे 50,000 से काम चल जाएगा और फिर वो आप देखो बाहर जाकर वो BMW शुरू करता है मारुति 800 क्यों नहीं तुम्हारे पास वो भी तो कार है ये भी तो कार है उसमें भी पता है इसको सर इसका स्टेटस है दिखता है ये दिखता नहीं है ये तो गया so people have status but when you do tonsillectomy you also do adenoidectomy along with that most of that remember I told you yesterday adenoid and tonsils are usually last together because they all a group they're all in the same family and so when you do adenoidectomy this is the instrument that we use for adenoidectomy what is it called St. Clair Thompson adenoid curate. St. Clair Thompson adenoid curate is the instrument that is used to do the adenoidectomy. Again, we can see there are different sizes. Same reason why different sizes? Different age of the child. You might have to use different size. St. Clair Thompson adenoid curate. So these are some of the important points about the procedure of tonsillectomy, the three instruments and the position of the patient and the images are important. In this case, images are important. And now we come to that all important thing, the methods, the complication of tonsillectomy. This is the most important complications. We all know the most common complication of tonsillectomy. What is the most common complication? Bleeding, hemorrhage. And bleeding of tonsillectomy can be divided into three types. You have primary bleeding, you have reactionary bleeding, and you have secondary bleeding. Other complications like joint dislocation. Which joint? Temporomandibular joint and atlanto-pharyngeal joint. Then tooth extraction is very common. The tooth comes out. Sepsis, aspiration. So a lot of complications possible. I need to remember them. They ask you. These are simple things. Logical activity. Bleeding can be three types. Dislocation of joints, tooth will come out. Infection can happen, which can happen because of any disease, any surgery, and of course, aspiration in the throat. Now there are 3 or 4 very, very important questions from here. I told you complication is very important. There are 3 or 4 questions. Question number 1. When there is atlantoaxial joint dislocation, this is a syndrome. They ask you what syndrome is this? This is called Grisell's syndrome. So this is one MC. What is Grisell's syndrome? This is atlantoaxial joint dislocation. It happens during this surgery, tonsillectomy as well as adenoidectomy. But which is more commonly going to cause this one? Adenoidectomy or tonsillectomy? Adenoidectomy. It is more common adenoidectomy as compared to tonsillectomy. That means if they ask you Grisell's syndrome is seen in each of the following surgery, then you have to look for adenoidectomy. If adenoidectomy is not given, then you can say tonsillectomy also. Next, the 3 types of bleeding. What is the basic difference between primary, reactionary, and secondary bleeding? What is primary bleeding? It is during the surgery. Bleeding at the time of surgery, while you are doing the surgery, is called primary bleeding. Reactionary is bleeding within 24 hours of surgery, and secondary is usually 5th to 8th day of surgery. So really, these names are based on the time of the surgery, time of the bleeding in relation to the surgery. Is it during the surgery, after the surgery, soon after, or many days later? Now, they ask you that if there is a primary bleeding, which is bleeding from at the time of surgery, what is the commonest source of bleeding in tonsillectomy? You know, tonsil has 5 arteries and a plexus of vein. What is the name of the plexus of vein? Paratonsillar plexus of vein, also pharyngeal plexus. 2 choices, A, B. Which one? Or you know, in South India, especially Chennai, and when I go to Chennai and Trivandrum, the yes and no is same. So you get confused. Yes, no. Seriously, it goes like this. So they know, they understand. If you need to subtle difference so that we cannot make up. I cannot make up. I keep telling them in the class, please yes, me, I say do this, no, do this. They say, okay, sir. That's the reflex, it doesn't go. And when I go for a PG class, by another institute, it's a big hall. There are 300-400 students sitting. And therefore, because it's a very big hall, you can't see, so that we stand on the stage and teach, you know, so that you can see. It's like a stage. And when you stand on the stage podium, you can only see the head. And 300 heads in my race, it is very nice. Seriously, it's a very nice. Visual is a very nice thing. I really love that. So, as a practice, which means I say, okay, someone say yes, someone say no, so the head goes the same. And it's very nice. As it is choreographed, you know, you feel like it is choreographed very nicely. It's a very nice thing. Yeah. Anyway, coming back to the primary bleeding is doing with time of the surgery, and the question was, what is the common source of bleeding? Those any other arteries of the vein, and the answer is vein. The bleeding happens from the paratonsillar plexus of vein. So remember that. Very, very important. Bleeding of tonsillectomy happens from the paratonsillar plexus of vein. But yes, somebody is saying that if there is arterial bleed, it happens from the main artery. Which is the main artery? Tonsillar dancer, facial artery. But that is less common overall. The more common cause of bleeding is the vein. And the second thing is, if there is a venous bleed, what do you do now? See, you are doing a surgery and the patient starts bleeding, and bleeding from any side due to any cause is an emergency. ABC, as you know, in emergency airway bleeding in circulation. It is bleeding that is an emergency, and now the most important thing for you is to be able to stop it. I told you already that tonsillectomy bleeding is quite common. So the question they ask is, what do you do to stop the bleeding? What is the first thing that you do to stop the bleeding? Bleeding from any side due to any cause. As somebody rightly said, the first thing that we almost always do is to apply pressure. How much time? 5 to 10 minutes. Why? What happens? Clotting. We are waiting for the clotting to happen. Clotting can take up to 7 minutes. Roughly, depends on where, obviously, it varies from person to person. So we wait for, average is 7. So you wait for 5 to 10 minutes and wait for the clotting to happen. And in most cases, the clotting will happen and the blood will stop. But suppose it fails. You have tried this, but it did not work. What is the next thing you do? What is the next option? We do cautery. If also this fails, ligation. What is ligation? I told you yesterday also. You apply suture. You tie the suture, isn't it? Take a thread and tie it around. So this is the sequence that we follow in a tonsillectomy to control the bleeding. Okay, this is about primary bleeding. Reactionary bleeding, as I told you, is a bleeding within 24 hours surgery. Again, the same cause. What is the commonest cause of reactionary bleeding? The most common cause is slippage of ligate. The ligate that you applied slipped. So perhaps it was not tightly applied, it was loose, and so it came out. बाद आपने बांधा था वो lose हो गया. So that's what it means. And the question is, what do you do now? The answer is immediate religation. You tie it again. So that's the answer. Immediate religation is done in case of slippage of the ligature. And the third one is just secondary bleeding, which is 5 to 8 days. What is the most common cause of secondary bleeding? Infection. Secondary bleeding is caused by infection. And the same question, what do you do now? Now you have two options. Of course, if it is infection, you can do antibiotic. One option is antibiotics to control the infection. And we all understand that antibiotics take time to act. They don't act immediately. It will take few days to, effective, 1-2 days at least. And if the patient is bleeding significantly, we can't wait for 3 days for the antibiotic to act. So if it is very mild bleeding, you feel it is not troublesome, you can wait, then this is enough. You give antibiotics and wait, and you call the patient after 2-3 days to re-examine and evaluate. But if you feel that bleeding is already significant, and if you can't wait, then of course you can do religation. Here also you can do religation. So religation is an option in secondary as well as in reactionary. Now in tonsillectomy, this is the most important slide. Or in tonsil everything, this is the most important slide. So you have to know this. And finally, different methods of doing tonsillectomy. I told you one already, which is snare. Remember? Snare. Then there is cold knife tonsillectomy. Cold knife is like cryotherapy. You have hardened knife. And these names are important. All these names are important. They ask you. They've already asked this exam. This question has already been asked in the exam many years back actually, but still. Methods for doing tonsil. West smear, cold knife, harmonic knife, debridement, cautery, laser, and the last one is the best method, plss radio frequency tonsillectomy. Radio frequency. The last name is this. The last name is this one. Plss radio frequency tonsil. This is relatively a new technology which is used in many other surgeries, not only tonsillectomy, it's used in many other surgeries. That's a very good technology, but like I said, newer technologies come with a lot of cost. New instruments, new machine, new training, so cost. It's costly. That's the only problem. And in India, as I said, cost matters. Right. So what are the 5 topics in tonsil? Indications, contraindications, procedures and instruments, complications, very, very important once again, and methods of intervention. Okay. Now, these are the 2 diseases which you might get confused. Both the images are important. Both the images are very, very important. The first one, as you can see, is a ranula, and the second one is Quincy. First one is ranula in the floor of the mouth, and second one is a Quincy. Quincy is also called peritonsillar abscess. And the definition of ranula, as you can see, is important. Ranula is defined as a retention cyst of the sublingual gland. This definition is in MCQ. What is ranula in MCQ? The image is also important. Right. Now, some books might say that ranula is not a retention cyst, it's an extravasation cyst. Ignore this. For you, ranula is a retention cyst. If retention is not given, then of course you can say extravasation cyst. The retention cyst is the correct answer for you. And of course, the second one is Quincy, peritonsillar abscess, where the tonsil is enlarged up to the uvula. Look at the image, tonsil is touching almost the uvula. So that's what can happen in Quincy. What is the pathogen? Same pathogen is called tonsillitis, which is Streptococcus pyogenes. So this is also called by strep pyogen. Now, Quincy, there are 3 more things you have to know in Quincy. A, what is this peritonsillar space? That means the pus lies between who and who in Quincy. And the pus in Quincy lies between the capsule of the tonsil. You know, tonsil has a capsule, and the bed of the tonsil. Bed of tonsil is mainly formed by a superior constrictor muscle. So instead of bed, if it says superior constrictor muscle, it is accepted. Quincy lies between, in Quincy the pus lies between the capsule and the superior constrictor muscle. And the presentation is, it is described as a hot potato condition. With muffled voice. Why is it called hot potato condition? because it's very painful. Like accidentally when you put something very hot in the mouth, and cause a lot of distress, you can't speak properly, you can't swallow it back. So it's a very similar kind of a catch-22 situation. And that's why it's called the hot potato condition. Very, very painful. And muffled voice. What is muffled voice? It's also called plummy voice. When you have food in the mouth and you try to speak, that voice is called muffled voice. Plum voice. Plum is that fruit, bukhara, aloo bukhara. So you put a plum in the mouth and treatment. So it's a clinical diagnosis. When you examine the oral cavity, you can see this enlarged tonsil, present the uvula and all that. Treatment. Treatment is the most important MCQ. What is the answer? Immediate incision and drainage. Immediate incision and drainage and interval tonsillectomy. This is the answer. Immediate incision and drainage and interval tonsillectomy. So right now you do incision and drainage and follow it up with a tonsillectomy. This is a complete treatment. Now what is interval tonsillectomy? Interval tonsillectomy is constantly done after a gap of 6 to 8 weeks. We do a tonsillectomy after a gap of 6 to 8 weeks of drainage is called interval. So there is a gap, interval between the IND and the surgery. And twins is the only disease where interval tonsillectomy is done. Otherwise, interval tonsillectomy is not done in any other disease. And the last disease of the oropharynx is Eagle's disease. What is Eagle's disease? It is the other name for enlarged styloid process. Eagle's disease is the other name for enlarged styloid process. When the styloid process becomes more than 2.5 centimeters, which is roughly 1 inch. It's a little more than 1 inch. The only complaint is throat pain with earache. Same reason, earache, same reason. Which one? Throat pain. Earache is again which nerve? I9 nerve. Same area, 9th nerve. Right. Now this pain is due to what? This pain is due to styloid process, isn't it? That's why the pain is called Styalgia. The pain is styalgia because it is due to styloid process. So basically, you have to confirm that the styloid process is enlarged, and to see this enlarged styloid process, you may have to do a CT scan. Even X-rays are sometimes useful. Of course, CT scan is better, but X-rays can also show sometimes the enlarged styloid process. And once you confirm it to treat, what do you do now? You have to do tonsillectomy and excision of the styloid process. Do tonsillectomy and do the excision of the styloid process. And this is a treatment of Eagle's disease. So this is complete oropharynx. Tonsil, everything about tonsils, quinsy, then renula and Eagle's disease. And then we go below the oropharynx. What is below the oropharynx? Laryngopharynx. And you already know that laryngopharynx has two parts. What are the two parts? larynx, and hypopharynx. We know this. And each one is further divided into three parts. Now, what are the three parts of the larynx? Supraglottis, glottis, subglottis. These are the three parts of the larynx: supraglottis, glottis, and subglottis. And hypopharynx also has three parts, and all the three are started with the letter P. So if you remember there are three P's in the hypopharynx, please to remember. This is MCQ. This is a very important MCQ. The first P stands for pariform fossa. Second P is post cricoid area and posterior pharyngeal wall. Once again, these three names, PPP, they are extremely important MCQ. Remember this. Pariform fossa, posterior area, posterior. In hypopharynx, only two things are important, nothing else. One is this, the three names. And the second thing about hypopharynx that is important is related to the wall. This is also a pharyngeal wall. And therefore, it will have those four layers. Yeah, the four layers, pharyngeal wall is mucosal layer, pharyngo-basilar fascia, muscle, and bucco-pharyngeal fascia. Same four layers. But it is a lowermost part. In the oropharynx, which we just discussed in the tonsil and the tonsil, in the oropharynx, the muscle was superior constrictor. Remember? The bed of the tonsil is found as superior constrictor. So the muscle is superior constrictor. Now tell me, this is the part of pharynx. So which is the muscle here? Inferior constrictor. Correct. So the muscle in the hypopharynx is the inferior constrictor. The muscle layer. Which is a very logical thing to understand. It's an inferior constrictor muscle. Now, inferior constrictor muscle in the hypopharynx has two parts. There are two muscles together, it is called inferior constrictor. One comes from the thyroid to the pharynx. Because it comes from the thyroid to the pharynx, this muscle is called thyropharyngeus muscle. And the other comes from the cricoid cartilage, and therefore it is called cricopharyngeus muscle. They are both part of inferior constrictor. Between these two muscles, there is a gap, a weak area. And that weak area, that gap is a name. What is it called? Yes? Pediens dehiscens. What does the word dehiscence mean? The word dehiscence is gap. So there is a gap, so it's called dehiscence, and the name of the gap is pediens dehiscens. So this name is very important. They ask you this dehiscence is between these two muscles. This dehiscence between thyropharyngeus muscle and the cricopharyngeus muscle, or cricopharyngeus, people like to call it. And both are part of the inferior constrictor, like I told you. And of course, inside this muscle, we have the mucosa also. Mucosal layer is the innermost layer. So mucosa in this area does not have a very good protection. Muscle is gapped, so there is no good protection. So the mucosa gets torn very easily in this area. And that's why this area is also called gateway of tears. The other name for this disease is gateway of tear. Tear is not asu. This tear is what? When somebody gets torn, the mucosa is torn, that's tear. So from the name you understand that this is an area where the mucosa does not have a very good support, the muscle, and so it often gets torn. It will have tears. Which is not very common. The mucosa will get torn is not very common. It needs a lot of force for that. What happens more commonly in this area, instead of mucosa getting torn, it prolapses. It comes out of this gap like this and forms a pouch outside. And this pouch is called Jenker's diverticulum. This pouch is called Jenker's diverticulum. Also called pharyngeal pouch. You can call it pharyngeal pouch. Right? So what it means is, suppose this is your pharynx. This is your pharynx. This is the mucosal layer. Then what is the next layer? Pharyngobasal fascia. Then what is the third layer? Muscles. This is muscles. Muscles. What is the last layer? Buccopharyngeal fascia. Remember, yesterday it is 4 layers and 3 compartments: nasopharynx, oropharynx, hypopharynx. In the hypopharynx, the muscle is what? Inferior constrictor, and the inferior constrictor muscle in the hypopharynx has 2 parts. There is one part here, one part here. One part is called cricopharyngeus, one part is pyropharyngeus. Between the two, there is a gap here. This gap is called Perian's basins gateway of tears. So what happens is, this mucosa, it will come out of this gap and form a pouch. This is Jenker's diverticulum, also called pharyngeal pouch. So through the gap in the muscle, it comes out. So what happens is, when this patient eats food, where the food is supposed to go down, some of the food comes and collects here. The food starts collecting some of it. This food is the food that you have already chewed. And you can imagine, if you chew the food and store it, even few hours later it's going to smell so bad. So that's the main thing. There's a bad smell from the mouth. And when the patient lies down, it comes out like this. The food comes out from the mouth again. That is called regurgitation. Regurgitation with foul smell. These are the 2 complaints. Whenever the patient lies down and says, so it is stored. And of course, the stored food is very bad smell. How do you diagnose this pharyngeal pouch? What is the investigation you do? Yes? Somebody saying we do the investigation called barium swallow. Yes. This is the investigation that is done. Barium swallow. It will show you the barium will fill the pouch, and when you take X-ray, you can see that pouch. I'll show you the image of this barium swallow, which is important. It's an MCQ actually. And this is the image, the second one, which is showing me the barium. This is the barium swallow, and it is a small arrow showing the pouch, which is explained in this diagram also, this image also. This is our pouch in the pharynx. Looks like the first one is showing the diagram, second one is the actual image of a barium swallow with a pouch here. This is for diagnosis. They'll just give you this image and ask you what is this. They can ask you this without any history, nothing. Just this image, ये क्या है? This is gentle diverticulum or pharyngeal pouch, whatever. And surgery is the treatment. They do surgery and repair this. Surgical repair is done in gentle diverticulum. Okay. So this is the only thing you have to know in the hypopharynx. Nothing else. The three parts and the gentle diverticulum that we discussed. But larynx is very important. Larynx actually is the most important part of the throat. Most important part of the throat is larynx. Why? The question is why? Because it is a very important function. And this girl will tell us, this girl in the white top, what's her name? Yeah, what's her name? Sarita and Kabita. Then Anjali. Okay. Rahul? Rahul? Did you Anjali dekhi? Okay. Sarita will tell us what is the most important बातें होगी. अब चले आगे. अच्छा, पूछ रहे थे ENT. अगर आपको ENT में कोई चीज समझ में नहीं आई या कोई डाउट है, in this room, who is the best person you should ask? Will always give the correct answer. है ना? So we ask your friend. नहीं, अग्रवाल. Not अग्रवाल. इस केस में अग्रवाल ज्यादा था. Okay. So Sarita will tell us what is the main function of the larynx. अंजलि will tell us. चलो, अंजलि तुम बताओ. बोलो, larynx किससे होता है? So चलो, कुछ भी बोलो ना. Voice production. Anjali says that this larynx is for voice production. How many of you think this is the correct answer? Raise your hands. Almost everyone. No one. If you don't raise your hand, I'll ask you what will answer. So better raise your hand if you think it is voice. Otherwise you must have an answer. Raise it. पूरा दिखाओ. I'm going to ask. I'm going to see किसने हाथ में उठाया? इन लोगों ने हाथ में उठाया. उसने उस लड़की ने. तुम बताओ. ये तो बहुत नया कुछ नया. मोदी से भी क्या आएगा? मोदी से भी क्या आएगा? कुछ नया नया ही कुछ है. ऐसे लगे. No, that's not the right answer. Anybody who knows the answer? This is not the correct answer. Okay. Voice is not the correct answer. That's right. Yeah, the main function of the larynx is protection of the airway. This is the correct answer. It's a very popular MCQ. Protection of the airway. Aspiration. Yeah, it protects the airway from who? It protects the lungs from the food that you eat and drink. It protects the lungs from the food that you eat and drink. It does not allow the food to go into the larynx and the lungs. Sorry. And this is called prevention of aspiration. The other word is prevention of aspiration. You know, if somebody starts aspirating and if you cannot control, death is imminent. Aspiration is over, and if you don't stop, death will definitely happen. The person cannot survive. So you cannot allow the food. It's life-threatening. So who prevents the food from going to the lungs? Larynx. larynx का मेन काम है, नहीं तो इंसान गया. Voice नहीं भी हो तो क्या करें? If you can't speak larynx, cannot produce voice, you're not going to die because of that. So that's why the main function of larynx is protection of the airway, which is like prevention of the aspiration. But voice is also a very important function. Voice is also a very important function. We also breathe through the larynx. Yes or no? We also breathe through the larynx. But there is one more function of the larynx. Who knows the four functions? So three I'll tell you: prevention of aspiration, voice production, breathing, and four. He says the fourth function I'm writing here is fixation of chest. This is the fourth function. Larynx has four functions. Mainly prevention of aspiration, protection, that is. Second is voice production. Third is breathing. And fourth is fixation of the chest. Right. What is the shape of larynx? Adult larynx is tubular or cylindrical in shape. Tube या cylindrical shape का होता है. So can I borrow paper? If somebody has already torn paper, fatawa पहले से दे दो. Okay. So when you say it is cylindrical, it's like this. This is a cylinder or tube, something like this, and inside it is hollow. It has to be hollow. Why? Because we breathe through this. Otherwise, we can't breathe. Right? Something like this. And the important thing is, what is this framework of the larynx mainly made up of? This boundary framework. What forms the framework of this larynx? Predominantly, will be cartilage. That's the cartilage of the larynx is very important. Discuss that. But along with the cartilage in the framework, we have some muscles and the membranes also. Okay, so framework of the larynx has cartilages, membranes, and muscles, but mainly cartilages. And inside there's a lining, like here had a lining of the squamous epithelium, isn't it? No, tonsil had a lining of squamous epithelium. Adenoid has a lining of ciliated columnar epithelium. If you remember, similarly, what is the lining of the larynx? Larynx is lined by, we can call it mucosa. When you say mucosa, it's a combination of cuboidal and columnar epithelium. Mucosa is a combination of cuboidal and columnar epithelium. So it's mucosa lining. Now, if you look at the larynx coronally, like this, my larynx, we call it like this coronally, and see from the front, what is the view called? Anterior posterior, AP. And only look at the mucosa. Forget the cartilages, forget the cartilage, the muscles, the mucosa, membrane. Look only at the mucosa. How does the mucosa of the larynx on an AP view look like? How do we draw the mucosa? We draw it like this. This is the larynx mucosal layer on an anterior-posterior view. All around this are the cartilages and the muscles and the membrane to support this movement. So this is your larynx on an AP view, basically from inside. Which is like this. See, if I show you this, which is the mucosal layer. If I start from here, please note, this is very important. This goes like this mucosal, this lining, this side, and on the other side, this is the mucosal lining, goes like this. If I remove this image, see, this is the line. This is your mucosal layer, and all around, you can see the cartilage and the membranes and the muscle. So this is the lines from behind. You look at the lines from behind. So there are two bulbs. This is the upper bulb. See, this is the upper bulb, and this is the lower bulb. This is the upper bulb. This is the lower bulb. In this diagram, this is the upper bulb, and this is the lower bulb. And I draw it like this. This is nearly the same thing. So this is the upper bulb. This is your lower bulb. And between these two bulbs is a balloon-like area. The area is ballooning up. These three areas have names, and they're very important names. So what is the upper inward bulge of the larynx cord? This is called the false cord. Also called the vestibular fluid. What is the lower bulge cord? True cord, also called the vocal fold. The two folds of cords, as we call them. And like I said, between the two, there is an area which is ballooning out. It's called either the ventricle or the sacrum. So these are the three important areas of the larynx. If you go from up downwards, the false cord, the ventricle, and the true cord. And in this diagram, the second one, you must be able to identify the three things. And you can easily identify, I'm sure. But talking about this three area, which among the three is the most important area? You know, say that's important. Which one is it? The third one. True cord. So, chai ki hamesha jeet hoti. True cord. Hai? It's called the vocal cord. Why is it called the vocal cord? Vocal means what? Voice. The voice is produced by the true cord. That's why it's called the vocal cord. That's why it is important. It produces the voice, the lower one. So I'll remove these names. And this is the most important thing in the larynx, the true cord or the vocal cord, because this is the one that produces voice. And you can't imagine a life without voice, isn't it? So where is the true cord if I ask you in this diagram? Then you say, if I draw two lines like this, one line and one line, then it is the area between the two lines as the true cord. So your true cord is this. This is a true cord of this side, and this is a true cord of this side. It lies between these two blue lines that I have drawn. And this area of the larynx between these two lines, which consists true cord, is called the glottis. This area is called the glottis. So this is the definition of a glottis. So glottis is the area of the larynx which contains the vocal cord. That you can see, contains the vocal cord. Everything above is the supraglottis, and everything below is the subglottis. And these are the three parts of the larynx. Do you know larynx has three parts? Supraglottis, glottis, subglottis. This is how we divide the larynx into three parts: supraglottis, glottis, and subglottis. Out of these three, which is the most important one? Glottis. Why? Because it contains vocal cord. Therefore, it can produce voice. That's why it's important. Isn't it? Now, glottis is able to produce voice because there is something special here. There is something special. Anatomy is special. And this is what they ask. What is the special anatomy of the glottis? Because of which it can produce voice. It has four special features. So the next thing is, what are the four special features of the glottis that we have to know, because of which it is able to produce voice. Number one is the lining of the glottis. You know that. What is the glottis lined by? What is larynx lined by? Because of except glottis. That's why it is special. That's very different. So the whole larynx is lined by mucosa except this area. This lining is different. That's why it is special. What is lined by? Squamous epithelium. So larynx is lined by mucosa except the glottis, which is lined by the squamous. So this red line that I've drawn is representing the squamous epithelium. Right. Now the second point is that below this squamous epithelium there is space. See, between the black line and the red line, I have deliberately left some gap, space. This space has a name. What is it called? The space is called the Rinke's space. It is deep to the squamous epithelium, the Rinke's space. Very important name, this one, Rinke's space. So they may ask you which of the following area has Rinke's space. They can ask you again, they can do brain, kidney, heart, larynx. So you have to notice in the larynx, Rinke's space. Third point, it is the narrowest part of adult larynx. And the fourth part, which is actually the most important part, is what you have to remember, is that no lymphatics in the glottis. No lymphatics in the glottis. This is MCQ. Next question. Where does larynx develop from? Where does pinna develop from? First and second branchial arch. Isn't it? Where does larynx develop from? MCQ. Raise your hand. Below. 4 and 6. Branchial arch. Larynx, there are some 4 and 6 branchial arch. Fourth arch will become supraglottis, and the sixth will become subglottis. Fourth will become supraglottis, sixth will become subglottis. So where does glottis come from? Glottis come from the border between the fourth and sixth are border glottis one. So glottis belongs to no one. It does not belong to the fourth arch. It does not belong to the sixth arch. It belongs to no one. It's a no man's land. Glottis is a no man's land. It belongs to no. It's a border area, and that's why there is no lymphatics. Right. The next thing you have to know is the difference between the adult larynx and infant larynx. Adult larynx and infant larynx, there are 4 differences. And number 1 difference is the location, which is higher up, which is lower down. Adult is lower, infant is higher. At what level is adult larynx? C3 to C6, and this is very, very, very important. The extremely important question, the level of the adult larynx. Remember this. Whereas infantile larynx, which is much higher up, is C2 and C3 level. C2, C3. Second point, shape. Adult larynx is like this. We know this. What is this? Tubular or cylindrical. Infant is like this. So some books call it cone shape, conical. Some books call it funnel shape. Narrowest part. Remember, glottis is narrowest. Glottis is narrowest. We discussed this. But look at the shape of the infant larynx and tell me which is the nearest part? Subglottis is narrowest. Now, against this line, put a question mark in. Put a question mark. Why? Because this point is controversial. Because some books says no, subglottis is not narrowest in infants. It is not true. But for you, this is the truth. आपने यही सही है. I put a question mark here so that if somebody tells you, like ठीक है, that is also okay. तुम्हारा विश्वास को छोड़, मेरा विश्वास को छोड़. You go with your belief, I go with my belief. My belief is this. Everybody has their own beliefs, yes or no? And the last point is, adults have harder cartilages. Infants have softer cartilage. Harder cartilage in adults, softer cartilage in infants. Again, this is important. The difference between adult and infant, they ask, especially the level. Level is very important. C3, C6, C2, C2. That figure is very important. The last one tells me, the last difference, that when we are born with very soft cartilage. As we age, our cartilage becomes harder and harder. And when we become elderly, when we cross 50, maybe 60, then there is also calcification of the cartilage. Calcium deposits, and they also get calcified at times in elderly. But all the cartilages cannot calcify. Some may not. Which one can calcify? We'll talk about that. But before that, you have to know how many cartilages do we have in the larynx. How many? How many cartilages? We have 3 unpaired cartilages and 3 paired cartilages. Three unpaired cartilages, 3 paired cartilages. Which are the unpaired cartilages? Cricoid, thyroid, epiglottis, and the paired cartilages are arytenoid, uniform, farnic. So another very simple thing, but it's a very popular question once again. All the 6 names are important. Now, these 2 names, you have to know nothing else. There's the names and nothing else. But the rest of the 4 cartilages are very important. So you know other names, other things also. Like they ask you that what type of cartilage is this? Hyaline or elastic and all that. So these 2 are hyaline cartilage. And this is elastic cartilage. What about arytenoid? Arytenoid is hyaline plus elastic. So some part is hyaline, some part is elastic. So if I ask which is the only elastic cartilage in the larynx, epiglottis is the only elastic cartilage in the larynx, and that's why there can be no calcification. Remember, larynx cartilage can undergo calcification, but epiglottis cannot have calcification because it is different type. It is elastic cartilage, they usually do not calcify. So rest of them they can undergo calcification. So this MCQ. This point is a MCQ, that which part of the larynx cannot calcify. And then they ask you the shape. They ask you the shape of cricoid only. What is the shape of cricoid? Ring shape. Yes, it's called signet ring shape cartilage. Very important MCQ again. It's another very important MCQ. The shape of cricoid, which is signet ring. If you remember ring, chalega, ring. It's only cartilage that is complete ring, pura goal hai, ring figure. There is no other cartilage which is ring shape. What is the shape of thyroid? We call it C shape or butterfly shape. C is correct. What is the shape of epiglottis?
Small pyramid.
Long leaf. पत्ते की तरह, पतला सा पत्ते की तरह. And what is the shape of arachnoid? A small pyramid. Something like this. Arachnoid is shaped of. So some books will call it small pyramid. Most books will call it small pyramid. But some will say boot. That long shoe boot, snow boot, that's all. So you should know the shape, but the question they ask is only this one. Which one? Signet ring. So these are some of the points of the cartilage line that let you know. Simple point. Paired, unpaired, elastic, highly, calcification, not readiness, shapes and all this. And they might ask you to identify by showing this image also. It's again not a very common thing. This anatomy not ENT, but still I'll tell you. This is what? This is thyroid. This one. And this one is cricoid, complete ring. This is epiglottis. Easy. Thyroid. Cricoid, epiglottis, easy. Can you see the arachnoid here? If you look at the last image, this, if you can look at this one, this and this, these are arachnoids. And what is this? This one? These are cricoid, these are tracheal part. This is trachea. That is with the trachea. So these are tracheal part. It's not important for us. Can you identify this? Of course you can. So tell me, what is the shape of arachnoid? Small pyramid or boot like this. Two, because they are paired. Am I right? In front of this is the thyroid. What is the shape of thyroid? C like this. This is thyroid. And between the thyroid and the arachnoid, there is a cord like this and like this. What is this cord? Vocal cord. This red line is a vocal cord. Cord of the cord. It's like a wire. And this cord produces the voice. So wire that produces the voice is a vocal cord. This is the anterior end and this is the posterior end. So this is how the vocal cords look from this side. Now because this is vocal cord, which part of the larynx is this? Glottis. You know glottis is the part of the larynx that contains the vocal cord. So this is glottis because it contains vocal cord. And a little while ago, I told you glottis is this. Between the two lines, the one that is shaded in pink color, isn't it? And now I'm telling you glottis is this. ये भी glottis है, ये भी glottis है. They look so different. ऐसे कैसे हो सकता है sir? The view is different. Anatomy is all about view. This is what section? Cornea section. And this is a side view. Side. Can I borrow one pen? So vocal cords are like this. like this. Two vocal cords. They are like this. There is a thyroid here anteriorly. One arytenoid is sitting here. One arytenoid is sitting here. So this is glottis. This over there is supraglottis. Below this is subglottis. So when you look at this glottis from the side like this, then you can see this pen, this diagram. But if you look at this glottis from behind and you have cut it, so you can only see this and this. Only this. So what is these two pink areas? One is this one. So if this is the vocal cord, one side say, you can see only this. So this is this. Okay, you are sitting. You hold this and turn it sideways, it becomes like this. You become this. So this is the side view and this is the front view. But when you examine the larynx, and when you do laryngoscopy, where do you pass the laryngoscope from? You pass the laryngoscope from the mouth. And then you see the line from the top. And that's axial view. वो ना तो cornal view है, and it is neither side view. When you examine the larynx, it is axial view, the top view, which looks very different. How do you draw the axial view? In axial view, the arytenoids are drawn like this. You draw the arytenoid like this, two arytenoids. In front, we draw the thyroid like this. This is thyroid. And between the two, there is a vocal cord like this. This is the axial. Same thing. The middle one is the axial view, that one is the side view, and this is the front view of the same glottis. So depends. Anatomy is about view. All are important, all are good. Which is the most important view for us out of the three? The one that is seen during laryngoscopy, which is like this, but we draw it like this. This is our best view, our main view. And these two vocal cords, they vibrate to produce voice. When they vibrate, they either go in or out, in or out. This is what the vocal cord does, in, out. This is called the vibration of the vocal cord, and this is the main thing that helps in producing the voice of the vocal cord. Now when it goes in, this movement is called they add, they touch, adduction. When it goes out, abduction. Adduction, abduction. So I'll remove this because this is not important for us now. This is the most important view. When it goes inward, this movement is called add. So it adduction. And when it goes outward, this is called abduction. And these are the two main movements in the vocal cord, adduction and abduction, are the main movements in the vocal cord. And because of these two, the voice is produced. Our voice is produced because of these two movements, adduction, abduction. Now tell me which of the two is more important for voice? Add or up? Add. Add is more important. But vocal cord has one more movement. It can also become tight and loose. We call it tension. The third movement in the vocal cord, it can become tight and loose, so we call it tension. The three movements in the vocal cord, adduction, abduction, tension. Tension is not required for voice production. As I said, voice production, we need only two, adduction, abduction. Not tension. We don't require the tension for voice production. If we don't require tension for voice production, why do we have this movement? So high pitch. When you want to change the pitch of the voice, high pitch, low pitch, then a tension is required. So if you don't have a tension function, if this is gone, it is not working, you can still have a normal voice production, provided this well. The only problem now will be you cannot change the pitch of the voice. So pitch is not very important. Voice production is more important. So adduction abduction is more important. Tension is not so important. इससे चला भी गया तो कोई खास फर्क नहीं पड़ता, right? But these are movements, whether it is adduction or abduction or tension, these are movements, and any movement in the body is carried out by muscle. So we all know muscle के बिना कोई movement possible नहीं. So these are movements, and there must be muscles involved, and this is the most important anatomy in the larynx that they ask in the exam. Which muscle causes what movement? Very, very important. So let us know the names of the muscles and the movements and the nerve supply. So tell me, abductor of the vocal cord. Only one. Posterior cricoarytenoid is the only abductor. I call it PCA because it is easy to remember that way. The only abductor of the vocal cord, PCA, posterior cricoarytenoid. How many adductors? 4 adductors. 4. Which are these 4 adductors? Lateral cricoarytenoid. So the posterior is abductor, lateral is adductor. Second adductor is interarytenoid. Then we have thyroarytenoid and cricothyroid. These are the 4 adductors. Versus only 1 adductor. 4 adductors versus 1 adductor. We have only 5 muscles in the larynx. Out of the 5 muscles, 4 are doing adduction, only 1 is doing abduction. Therefore, who will do the tension? Who will do the tension now? The last 2 adductors are also tension. The 2 adductors. Which 2 adductors? Cricothyroid and thyroid. These 2 are tensors also. These two muscles are tensors also. But the first 2 are not tensors. They are only adductors, isn't it? The first 2 are only adduction, nothing else. So the first 2 are called pure adductors. Pure adductors. Because they are pure, they are not doing anything else except adduction. But the next 2 are not pure adductors because there is something else also, and that something else is tension. But out of the 4 adductors, the last one is a weak adductor. It's very important. It's a weak adductor. Cricothyroid has adduction power, but the power of adduction of cricothyroid is very weak, and therefore it is hardly ever used. It is hardly ever used. Which means every time there is adduction, only 3 muscles are doing that function. Which 3? These 2. This one will not participate because it is not required. कमजोर है तू बैठा रहा, हम संभाल लेंगे. पता है 4 दोस्त हैं, कोई काम करना बड़ा, 3 बोलते हैं तू बैठा रहा, तू कमजोर है, हम संभाल लेंगे, तू आराम कर. ये बोलता है नहीं, मैं भी कहता तू टेंशन ले, because it is a main tensor. तो टेंशन ले, काम हम करेंगे. So cricothyroid is the main tensor, but weak adductor. Right? This is a very important sentence. Cricothyroid is a main tensor, but weak adductor. मतलब tension इसके बगैर नहीं हो सकता, but adduction is a काम नहीं. In tension, this does not function. In adduction, this one does not function. So although we have 2 tensors, only one is doing the function. One is useless. And although we have 4 adductors, only 3 are doing the adduction, one is not helping adduction. And this creates a lot of problem in the student's mind. See, why I am written like this? So that you appreciate 2 things. This is very important. Don't forget this. दो बात है. One is truth. सच्चाई क्या है? The truth is that one abductor, there are 4 abductors, there is no doubt about that, and there are 2 tensors, there is no doubt. This is the truth. But when the function is happening, actually क्या होता है? Actually, abduction, only one is functioning, but when there is adduction, only 3 out of 4 are functioning. One is not doing the function. And when there is tension, only one is doing the function. Which means, if my cricoid is gone, my adduction will be normal. And if my thyroid is gone, my tension will be normal. Are you getting my point? So these 2 muscles, they have the function. One is adduction function, one is tension function, but they are hardly used. So if this is happening, if these are normal, these functions are normal. Right? And these 5 muscles are supplied by, or before that, if my cricoid is gone, what will happen to me? I will have normal voice production, but I will not be able to have a high pitch voice. Isn't it? Is that clear? And if the voice production is normal, life is normal. आवाज पैदा हो रही है, बातें कर पा रहे हो और क्या चाहिए? टेंशन नहीं हो रही है, हाई पिच नहीं है. क्या फर्क है? When do we use tension in the voice? High pitch. When do we use tension? High pitch कब यूज करते हो? गाना गाते. Yeah. कितने लोग गाते हैं गाना? कितने लोग गाना गाते? Seriously, not बाथरूम सिंगिंग की बात नहीं. Seriously, not function, मतलब वैसे गाते हैं. 4 दोस्त बैठे, हाँ ये गाएगा तो ये गाता है. ऐसा कोई है? Don't point at others. If you are a singer, raise your hand. बाकी तो सब है. 1, 2. चलो, in a class of 100 people, only 2 can sing. 98 do not. I am one of those 98. I don't sing. So most of us don't sing. What I'm trying to say is most of us don't sing. That means most of us don't need the tension. है ना? तो हमारे तो बेकार है कि thyroid muscle. What do you say? Yes or no? Yes or no? Yes sir. But क्या सिर्फ गाते वक्त ही सही है? और कब चाहिए? चिल्लाते वक्त भी चाहिए. चिल्लाने का मतलब अंग्रेजी में बोलो. अंग्रेजी में बोलो. चिल्लाने का मतलब क्या? Shouting. Shouting and screaming are 2 different things. Shouting is when you speak loudly. And loud voice is not necessarily a high pitch voice. Loud and high are 2 different things. So when screaming, you are actually using the high pitch. When you're shouting, you are not necessarily speaking the high. So without high pitch, you can still speak loudly. Loudly, vocal cord को ज़्यादा vibrate करना. जितना ज़्यादा vibration, उतना loud voice. So even with the absence of the cricothyroid, you can still speak loudly, but you will not be able to scream. High pitch नहीं होगा. Is that clear? So you understand that high pitch is really not an important thing, unless of course you are a professional singer and things like that. Then of course it is problem. So it is not very important. But like I said, these are all supplied by nerve. Which nerve? Which nerve? The only nerve in the larynx is the 10th nerve. Larynx में कोई nerve है ही नहीं. इसके अलावा 10th vagus. Now what I am going to tell you, ladies and gentlemen, larynx की anatomy की सबसे important slide. This is going to be the most important slide of the laryngeal anatomy. If you remember and understand this, life is going to be easy. If you don't understand this, life is going to be screwed up. I don't want to use the F word. You want to be screwed up. So please sit straight with the mind open, so that you sit straight on the semester. Everyone. Okay. This is going to be extremely important. So the only nerve in the larynx is the vagus, but vagus supplies the larynx via 2 branches. One enters the larynx from the top, and therefore it's called superior laryngeal nerve, and the other enters the larynx from below, and it's called recurrent laryngeal nerve. So these are two main branches of the vagus in the larynx. Out of this, the superior again divides into two. One is called internal laryngeal nerve, and one is called external laryngeal nerve. So one goes inside the larynx, internal, one means outside the larynx, external. Recurrent does not divide like this, so it remains recurrent laryngeal nerve. RLN, it remains like that. Which means ultimately we have three nerves in the larynx. So the three nerves: internal laryngeal, a branch of superior; external laryngeal, again a branch of superior; and recurrent, and they all ultimately come from the vagus. Ultimately, they are coming from the vagus. Now, supply. Internal is purely sensory. It's a purely sensory nerve, and so it cannot supply muscles. Sensory to which part of the larynx? बड़ा आसान है. Sensory to which part of the larynx? ऊपर से आ रही है, so ऊपर वाला part, and the upper part of the larynx is called supraglottis. So it supplies sensory to supraglottis. ऊंचे लोग ऊंची पसंद, तो ना ऊपर से आएगी, ऊपर वाला part को supply करेगा. That's understood. Now, interestingly, the other one is purely motor. It is purely motor. It can only supply muscles. Out of these muscles, which ones? Only one muscle. Which one? Precothyroid. This one. This is the only muscle supplied by external laryngeal nerve, a branch of superior laryngeal nerve. Precothyroid. It supplies precothyroid muscle. Therefore, what is the function of this nerve? High pitch, tension and high pitch. This is used only for high pitch and tension of the. So what does recurrent supply? It supplies all other muscles. All other muscles. In this diagram, all this, they are supplied by recurrent laryngeal nerve, and this is supplied by external laryngeal branch of superior laryngeal. So very easy. Now tell me, what is the function of recurrent laryngeal nerve? Adduction, abduction, therefore voice production. It is mainly for voice production. अगर ये नहीं गई तो फिर voice production है. If the recurrent is gone, the voice production suffers. There is no adduction, abduction. And what is the function of external laryngeal nerve or superior? High vocal cord tension and high pitch. So if external is gone or superior is gone, then voice production will be there, but no high pitch. You cannot have a high pitch voice. Is that clear? So I told you, please note that if this one is gone, there will be a low pitch voice and loose vocal cord. Loose vocal cord. Tension का opposite क्या था? Loose. And this one is gone, what will happen? No voice. That is called hoarseness of voice. Hoarseness or dyspnea. What is dyspnea? Difficulty in breathing. So if the recurrent is gone, then the hoarseness, voice production is affected, which is hoarseness, or dyspnea, which is difficulty in breathing. One of the two will happen. So that is understood, because this is mainly for voice production. If this is gone, the top one, तो क्या होगा? That means what is the function of this nerve? It's about the supraglottis, but how does it help? What does it do? it prevents aspiration. So if this is gone, the patient begins to have aspiration. So now you know the defect of which muscle can cause what problem in the larynx. And this is, as I told you in the beginning also, is your most important slide of the anatomy of the larynx. You have to remember this. Okay, let's see some examples. For instance, if I tell you a patient with vocal cord palsy, laryngeal palsy, as an aspiration, as a main complaint, which is always wrong. What do you say? Internal is wrong. If I say this patient of vocal cord palsy has a loose vocal cord with low pitch voice, external, and the patient of vocal cord palsy has hoarseness of voice, recurrent is wrong. If I ask the vocal cord palsy patient comes with aspiration with low pitch and loose vocal cord. Aspiration with low pitch and loose vocal cord. Superior. Then see, you extrapolate this. One is this symptom I told you, and one is this symptom. So you go backward, you don't know they meet here. So this is gone. So this is how you track. Suppose I tell you a patient of vocal cord palsy comes with aspiration and dyspnea. Aspiration and hoarseness. Aspiration and hoarseness of voice. Tonsil is gone. Vagus. The symptoms are aspiration and hoarseness. Where do they meet? They meet here. So vagus is gone. So this is, so if you have this particular chart, then depending on the symptoms that are given, you can easily extrapolate. The symptoms को ध्यान देते that nerve is gone. So that's how you have to practice it. That's why this slide is, and this is very commonly asked. They give you the symptoms, and I've seen that every time they ask this question, 95% of people get it wrong. बाद में सब पसंद ये क्यों होगा, आपको ये देखो, सब कुछ यहाँ पे. If you remember this, आपको कुछ ही याद रखने लगे. You don't have to remember, learn anything. Remember this, that's everything here. Right? And this is the most important anatomy of the larynx: the muscles, their functions, and the nerve supply. These two slides, this one and this one, are the most important slides as far as anatomy of the larynx is concerned. And you have to, ये तो आपको याद रखना ही पड़ेगा larynx में. Besides that, if you can remember the cartilages, this slide is also important. Shape, eyelid, calcification, non-movement, all this. I was surprised to know कि जो अभी एग्जाम हुआ था आपका INICET, which is sample exam, AIMS exam. There are 3 questions from these 2 slides. This slide and this slide. There are 3 questions, and there is 1 question from this slide. These 3 slides, there are 4 questions in AIMS exam. Can you imagine the importance of these 3 slides? It's so important. So आपको ये करना ही पड़ेगा. There is no alternative. And the last anatomy question is the length of the vocal cord. What is the length of the vocal cord in male and what is the length of the vocal cord in female? In male it is 24 to 25 millimeters, and in females it is 16 to 17 millimeters. This is the length of the vocal cord in male and female. 24, 25 in males and 16 to 17 in females. And this is the main reason why a male voice is different from female voice. इसी की वजह से mainly there's so much of difference in male and female, mainly because of the length. The other factors also, but this one is the main. Right? So this will complete all the anatomy of the larynx. Now we talk about diseases, but I think we deserve a break. Once again, khali plate doesn't know the pala, isn't it? We need to have food, and I think 30 minutes is sufficient to eat.